Welcome to Clinical Minute. Vanessa is a married 30-year-old woman, G1P0, presenting for an OB visit at 32 weeks LMP. She is pregnant with twins. You greet her and ask how she's feeling since her last appointment. She shares that she's been having really bad heartburn, especially in the middle of the night, and is still vomiting maybe 3 or 4 times a week. She laughs, rolls her eyes, and says, "So much for the morning sickness going away after the first trimester, and it should be called all-day sickness." You smile and tell her that you're sorry to hear that she hasn't been feeling well, and reassure her that it's not that unusual for women carrying twins to experience what she's describing. For the heartburn, you suggest that she sleep with her head and chest raised, and recommend an over-the-counter medication. From talking with her previously, you know that she's tried everything short of prescription medication for the nausea and vomiting, and that she doesn't want to use prescription medication. You conduct physical and ultrasound exams with normal findings. You tell Vanessa that everything looks great with her and her twins, and that you'd like to talk to her about post-delivery birth control for a few minutes, if that's okay with her. She says, "Sure," and you ask her to get dressed and to let you know when she's dressed by opening the exam room door. With a singleton pregnancy, you would normally wait until the patient is further along, usually around 36 weeks, before bringing up the topic of postpartum contraception. However, knowing that women carrying twins often deliver early, you wanted to make sure that you get a chance to talk about this important topic with Vanessa. You plan to use a shared decision-making model in which you query to identify preferences, ask open-ended questions, provide information about side effects, effectiveness, and use of method, give context about options, ensure access to method placement and removal, allow time for questions, ensure informed consent. When you see that she's opened the door, you knock, enter when you hear her say "come in," and sit down on the stool at the foot of the exam table. You reiterate that you'd like to talk with her about what she'll do about birth control after she delivers her twins. You ask, "What are your thoughts about birth control after you deliver?" She says that she's been so focused on this pregnancy that she hasn't really thought about it. You tell her that's completely understandable. You go on to ask, "How many children in total would you and your partner like to have?" She responds that they'd always said they'd like to have 3, but she's not so sure about that now, with twins on the way. She goes on to say that it would be a while before they'd even consider a 3rd. You ask, "When you say a while, how long are you thinking?" She says that it would be at least 2 or 3 years. What are your next steps in counseling and educating Vanessa about her options? You know that in the United States, the use of long-acting reversible contraception, or LARC, increased by 6% from 2008 and 2012. You also know that LARC methods, including intrauterine contraception, or IUC, and implants, are considered top-tier methods because less than 1 pregnancy per 100 women occurs in a year with the use of these methods. These methods are more effective in preventing pregnancy than the second-tier methods, not due to their mechanisms of action, but because they are easier to use properly. Once the top-tier methods are initiated, they require little additional action to provide highly effective contraception. Further, in the Contraceptive Choice Project study, 9,256 women ages 14 through 45 were counseled about all methods of contraception. After receiving counseling, 75% of women selected a LARC method. More than 40% of women ages 18 through 20 chose intrauterine contraception, or IUC. Among the women who selected IUC, 84% who chose the copper T IUD, and 88% who selected the Lmg IUS, Mirena, were still using the method at 1 year. In contrast, only 55% of women who chose a non-LARC method, the contraceptive pill, patch, or ring, were still using their chosen method at 1 year. This slide shows the 3-year continuation rates. The rate for the Lmg IUD was 69.8%. For the copper T IUD, 69.7%. And for the implant, 56.2%. Overall, the continuation for LARC methods was 67.2%, while for non-LARC methods, it was 31%. You remember reading the American College of Obstetricians and Gynecologists practice bulletin that stated, observational studies of progestin-only contraceptives suggest they have no effect either on a woman's ability to successfully initiate and continue breastfeeding or an infant's growth and development. Finally, having reviewed Vanessa's medical history, you know that she doesn't have any absolute contraindications for IUC or the implant. With all of this in mind, you say to Vanessa, it sounds like you want to keep your options open for a third child, but you'd also like a birth control method that will prevent pregnancy for a few years. Is that accurate? Vanessa smiles and says, exactly. You tell her that there are 3 options that do a very effective job of preventing pregnancy for a few years, but aren't permanent. You explain different LARC options to her using diagrams to aid understanding. You invite her to stop you any time she has questions. The first type of available IUC is the copper T intrauterine device, or IUD. It's a small T-shaped device made of plastic wrapped with copper. The copper T IUD is approved for up to 10 years of use, but it can be removed earlier if a woman decides she wants to get pregnant. The copper T is thought to work by preventing fertilization, preventing the egg and the sperm from meeting up. It starts working immediately, so no backup birth control is needed. However, the copper T doesn't provide protection from HIV and other sexually transmitted infections. Vanessa stops you and asks, wait, aren't there a lot of problems with IUDs? My mom had one back in the day, and she said they're dangerous. You say that a lot of patients have that question, mostly because older IUDs did have more common complications. Modern IUDs have many fewer complications. Like any contraceptive method, they do have potential side effects and some possible complications. The copper T can increase the length of time and amount of menstrual flow and menstrual cramping. Expulsion from the uterus is rare, occurring in only 5% of users, but is the most likely cause of failure. Expulsion is most common within the first 3 months after insertion. Uterine perforation is a rare complication, occurring approximately once every 770 to 1,600 insertions. There's a small increased risk of pelvic inflammatory disease during the early post-insertion period that can be treated without removing the IUD in most cases. There is also a second type of IUD, the Lmg Iud. There are 4 different Lmg IUDs on the market. Like the copper T, Lmg IUDs are made of plastic. However, they do not have copper on them. Instead, they slowly release small amounts of the female hormone progesterone. Depending on the Lmg Iud used, they are approved for 3 to 5 years of use. A backup method of birth control needs to be used for 7 days after insertion. Like the copper T, the Lmg Iud doesn't provide protection from HIV and other sexually transmitted infections. Lmg IUDs work by thickening the cervical mucus, making it harder for sperm to swim up into the uterus. In addition, they make the lining of the uterus, or endometrium, thinner and less welcoming for a pregnancy. During the first 3 to 6 months of Lmg Iud use, bleeding may be irregular, and the number of days with bleeding or spotting may be increased. After that, bleeding usually decreases. Like with the copper T, complications are rare and include perforation, infection, and malposition. You go on to tell Vanessa that the third option of long-acting reversible contraception is an implant. It is a single thin, flexible rod 4 centimeters long. The implant is placed right under the skin in the upper arm and continuously releases small amounts of progesterone over 3 years. Like any of the IUDs, it can be removed sooner if the woman decides to get pregnant. A backup method of birth control needs to be used for 7 days after insertion. Like the other methods you've discussed, the implant doesn't provide protection from HIV and other sexually transmitted infections. The implant works by preventing the woman from ovulating or releasing an egg. It also thickens the cervical mucus, making it harder for sperm to swim up into the uterus. Finally, it makes the lining of the uterus, or endometrium, thinner and less welcoming for pregnancy. Immediately after insertion, women may experience slight bruising and discomfort. Side effects include changes in menstrual bleeding patterns, including initial spotting and cramping. Many women find that they have less predictable, lighter periods as time goes on. Other possible side effects are the same as for other hormonal birth control methods, including headache, weight increase, acne, breast pain, and abdominal pain. You pause and say, "I know that I've covered a lot of information in a short time. What questions do you have?" Vanessa asks, "How long after I give birth do I have to wait to get birth control?" You explain that any of these methods can be inserted right after she gives birth, in the delivery room, assuming there are no major complications with the delivery. Then she asks, "Do I have to decide today?" You tell her she can take time to think about her options and to talk them over with her husband if she would like to. You give her information about all of the LARC options to take home. At her next visit, Vanessa tells you that she thinks she'd like to have the implant inserted after delivery, but she has one question that she forgot to ask last time. "I'm hoping to breastfeed. Is there any problem with breastfeeding with the implant?" You tell her that none of the long-term methods you discussed, including the implant, cause problems with breastfeeding. They don't affect milk production, and they have no negative effects on the baby, or in her case, babies. You take the opportunity to tell her that you know many twin moms who've breastfed successfully. You also provide referral information for a local lactation consultant, explaining that some women find they need a little extra help and support with the breastfeeding process. You go through the informed consent process thoroughly, making sure to describe the insertion procedure, aftercare, and possible risks and complications. You make sure that Vanessa knows that she will need to come in to see you or go to an emergency room if she experiences abdominal pain more severe than her usual menstrual cramping, as this could be a sign of an ectopic or tubal pregnancy. You also inform her that she can have the implant removed at any time. She does not need to keep it for the full 3 years. She signs the informed consent form, and you give her detailed written information about aftercare and warning signs to take with her. Vanessa delivers healthy twins vaginally at 37.2 weeks. You insert her implant for her without incident. You invite her to call or schedule an appointment with any questions or concerns she has.